Welcome back to the Psychiatry Boot Camp podcast. I'm Dr. Mark Mullen. Well, what could be more foundational than the clinical interview? I remember feeling very overwhelmed as a third-year medical student on my psychiatry clerkship because of the complexity of the information that we're trying to gather. We're talking about learning who a person is, having them tell their story, learning about what's important to them, what problems they're having, and what makes them tick. It's impossibly complex, so we need to be really systematic about how we obtain the information. In this episode, we'll talk through interviewing principles, do's and don'ts, and then we'll walk through all of the different information that we're trying to obtain, how to ask for it, and how to organize it. At this point in my third year, I thought I had my intake 100% optimized, but after talking with Dr. Raml, I've changed the way that I ask several questions, and I've already noticed that I'm building a better alliance and getting better information, so I hope you have the same experience. Okay, let's get started learning from today's expert, Dr. Dana Raml. Dr. Raml, I'll ask you to introduce yourself to our audience.
I'm Dana Raml. I'm a psychiatrist here at the University of Nebraska Medical Center. I do a lot with med student education, particularly with fourth-year medical students transitioning into psychiatry. So I'm excited to be here today.
And you're also pertinently one of my bosses at the outpatient clinic at Nebraska Medicine. So thanks for being willing to take on such a broad topic. Today, we're talking about clinical interviewing. I think this is a really dauntingly broad topic because the clinical interview can change a lot based on where you are. So, I think about a clinical interview on the consult service where you're doing a very straightforward capacity assessment is going to be a lot different than sort of a 90-minute comprehensive outpatient intake interview where the patient comes in with a chief complaint and you're spending a lot of time, screening all of the different symptoms and parsing it out. Is there any context that you would like to lay in terms of how you think about this when you teach it?
Before we get too much into context, really the foundations of what are the goals of an interview, and then that will guide sort of what the interview looks like because context is part of that goal.
Okay, so when you are going into your first encounter with a patient, what are your goals?
So I would think about determining what is the patient there for, getting the clinical information that you need to make your treatment plan, whether that's just disposition or whether that's going to be like an outpatient psychiatrist and creating the ongoing management plan. That's, I think, tier one. And then to do that, you have to be also cognizant of the alliance that you're developing with the patient and getting the information that you need to create that plan. So if you're on a consult service doing a capacity evaluation, the information that you need to gather is going to look a little bit different. Like I said, than if you are in the PES and you're getting a dispo, can I discharge this patient or where does this patient need to go? Versus if you're in the outpatient setting and you're going to be working potentially with ongoing med management with some psychotherapy for, a more extended period.
Gotcha. So I think one of the really important things you just said is the building of that therapeutic alliance. So, one of the primary objectives in any psychiatric initial encounter is really just to build rapport. And sometimes I think that clinical data and the treatment plan parses itself out more over time, but you really need to get started building that therapeutic alliance on day one, not only because it helps you to get data to treatment plan with, but also because we know that psychiatrists who have a better therapeutic alliance with their patients have better outcomes. I will say, in medical school, I would watch some of the psychiatrists talk to their patients, and I would think deliberately, how do they know what to say in this situation? It feels like building a therapeutic alliance is kind of intangible, kind of difficult to learn. Do you have any concrete strategies to share with us about how to build the therapeutic alliance that any trainee could follow?
Yeah. So I think for most patients, there's some really easy strategies that you can employ. And even if connecting with people is not your strength, which you probably aren't going into psychiatry if that's the case, but if you are, there's some easy pearls that anyone can do. Calling the patient by their name and asking them what they like to be called, not assuming first name. Some patients really prefer a different name than legal name on the chart. Some patients do prefer that. So clarifying what they want to be called and using that throughout the interview, engaging, showing interest, making eye contact where appropriate, and having your body language signal, hey, I'm interested in what you have to say. So more open posture, nodding along, that can be really helpful for patients. That verbal affirmations and those nonverbal cues combined can really help keep the patient talking on a subject area that you want. Another important thing that you can do is not feeling like you have to fill every space of your patient interview with words. So sometimes letting the patient sit in silence, that gives them time and the space that they need to feel comfortable in sharing with you, which can often be really intimate things. and tough discussions. Some other strategy is paraphrasing back to the patient what they're saying. And that also serves not only the purpose of letting them know, hey, I hear you, but also confirming, did you hear what they were trying to say? So I can sort of be twofold there. And coming back, I had mentioned these types of things work well for most patients. The one caveat to that would be if you have a patient who is demonstrating any paranoid pathology, and sometimes that overly connection or frequent use of their name can come off with the opposite effect. And so in those situations, you don't want to add those sort of affirmations of, oh, I know how you might have felt there. That will sometimes spook a patient if they're having paranoid processes going on. So in those cases, you actually get a little bit better rapport if you're able to stay really more neutral and not infer anything from what the patient is saying, but just kind of so you're saying XYZ happened, and confirming their statements in that manner.
Right, because they may actually think that there is some sort of thought broadcasting going on or thought insertion, etcetera. And
Yeah, or sort
so
of that, how do you know how I feel? Or how did you make that connection? And it can be unsettling for them.
and then the other thing that I'll point out about what you said in terms of kind of reflecting, paraphrasing back to the patient, sometimes paraphrasing something, giving it back to the patient, getting a negative response, as in, "No, no, no, that's not what I mean at all," is just as enlightening, if not more enlightening, than if they say, "Yes, doctor, exactly." Sometimes a patient, depending on kind of how things are being organized in their brain, might have a lot of cognitive distortions or a lot of self-blame or a lot of guilt, and that comes out in the way they tell their story. And so one strategy that we can use to kind of insert a little bit of healing into the interview process itself is to, when we say something back to the patient, we are looking for the adaptive trait. So they might say something as in, "I can't believe I ever, would act that way," or "I really shouldn't act that way." And we might point out that in another context, that action was very adaptive. It's just that maybe now it's maladaptive, or, well, you may be feeling this way or you may have acted this way because it helped you to survive. And you can kind of add that into your interpretation as you are reflecting it back to the patient to kind of remind them that while they're seeing it one way, you're repeating the facts back to them, but you're reminding them that there might be kind of a less toxic way to look at it.
Yeah, definitely. I think that brings up another great point is, I had mentioned earlier that a goal of the interview is to get disposition and treatment plan ongoing for the patient, but really that sort of minimizes the utility of the interview itself as therapeutic opportunity and a treatment intervention. Just like you mentioned there, some of those subtle shifts and maybe gently challenging if you have a patient who you notice, so maybe maladaptive um, interactions or traits. And if you feel like you have enough rapport built up and you are in a situation where you can gently sort of redirect those, it can be a good time to get a patient thinking about that and identifying those traits and kind of moving forward, hopefully, with a slightly different perspective that may be more effective in their future interactions.
So it sounds like you're suggesting sort of a lot of active listening strategies. Any other concrete tips on how to build the therapeutic alliance as you interview?
So I think active listening, the other thing that I think patients pick up on is how conversational it feels, which as a psychiatrist or any mental health practitioner or anyone doing a clinical interview, there's sort of two goals to that. You can have the goal of getting all the content that you need to cover to make some of those decisions, formulate your diagnosis, and really understand what's going on. And then there's the goal to make things feel conversational and have that sort of really natural feel for the patient and get that rapport. And how do you marry both of those things? And they're not inherently in conflict with each other, but I think anyone who's done a clinical interview can say that at times they seem in conflict with each other, with one another. So when we think about ways we can marry those two ideas, really being intentional with the types of transitions that we're setting can help get the content we need and maintain that rapport that we're looking for. So I think in a perfect interview setting, which is not realistic, most of those transitions would be spontaneous. You would be at a content area, the patient would give you the information that you need, and then they would segue into the next topic, and the clinician could follow with something such as a tell me more about that and segue nicely into that next section. Patients don't know what information we are trying to gather. They're trying to help us out usually, but the spontaneous kind of flow through the interview patient-directed is unlikely to happen for too much of the interview, but oftentimes it will happen somewhat. So that's first. The one thing to be careful with that is avoid the wandering patient. So sometimes I see with people who are novice interviews or maybe even just tired at the end of a long clinical day, where they can get kind of stuck with the wandering patient and follow patient into some of these content areas, into new content areas that, okay, we haven't finished covering this really important thing I'm talking about here. And so sometimes I see the desire to be sort of alter conversational, kind of make these very extended interviews because the clinician isn't redirecting back. So when you find a patient going into a content area that maybe you're not, maybe it is relevant, but you're just not ready to cover it because you haven't finished your first sort of piece of what you're looking at, you can pivot back and gently like, hey, that's great. I want to cover that more later, but I really want to make sure I finish learning more about your sleep or whatever you were talking about previously.
And this can
Uh,
feel rude, I think, at times to sort of interrupt a patient to use a transition statement to talk about something else. But a lot of patients really want you to do this. I think of one patient that came into my office for an outpatient intake, and she was so anxious and she just would not stop talking. And usually you kind of let the patient talk for the first 5, 10 minutes. And I just very politely kind of interrupted. I reminded her that we had a lot of content to get through. And she was shocked that I interrupted her. But she was so grateful because a couple months prior, she had been to a provider somewhere else who I think let her talk uninterrupted the entire intake, if at least that's what the patient said, and was diagnosed with bipolar disorder. But when I interrupted her, she was so happy to have some structure to the interview and to be able to answer specific questions because that's why patients come to us is for our expertise. They're not going to walk in and tell you everything that you want to know. So if you do find your interview kind of trailing off, it is totally acceptable to use a transition statement, redirect them to somewhere that you think will be more productive because we are working under some limited time circumstances.
Yeah, and that's part of being a skilled interviewer and part of our job is being able to do that. And I agree with you. Very rarely do I have patients, even I've had, some patients with significant manic symptoms and pressured speech, even they don't respond negatively to being redirected. Sometimes need more redirecting based on some of that pathology, but people generally do respond well to it. And I think, like you said, they don't know what information we're trying to get or what we need to do our job. And so sometimes I think they're sort of like, "I'm just talking until you sort of point me in the direction that you want," and they assume if we're listening and nodding along that it's valuable information for us, and sometimes it is, and sometimes that, maybe we have what we need, but there's other more valuable topics that we really need to get to.
And as the assistant clerkship director and the director of the outpatient clinic, you've seen hundreds, maybe thousands of trainees interview. Is there anything else that you would recommend we avoid when interviewing a patient?
So other things that I can see trainees sometimes get caught up in are, using too many jargon or medical phrases that the patient's not sure what's going on. And sometimes this can even be things that might have a different meaning in medicine versus for a layperson. So asking a patient, have you ever had a panic attack? Well, that's a term that I hear a lot sort of in the layperson community. And so a patient may not know what we're really asking for from a mental health perspective. So instead of asking that, really describing, have you ever had a period of time when you had a sudden spike in anxiety? Even if your anxiety is high at baseline, this was way worse than usual, where you were feeling short of breath or and sort of describing it for the patient in a way where if they answer yes to that, you can feel more comfortable saying like, yeah, they really have experienced panic attacks and these are the type of situations they are versus just asking about panic attacks and patients aren't really sure what that means. The other diagnosis I see that sort of creeping in on bipolar disorder, I feel like that's often thrown around incorrectly just to describe someone with a labile mood, which is stigmatizing in and of itself for people with bipolar disorder. So instead of asking about these names, but really getting into what type of things would we see if we're looking for bipolar disorder.
Okay, so here's another one that I think is a little bit controversial in interviewing. Maybe if I asked 10 different supervisors, I would get 10 different answers about this, but just kind of your personal take on it. I think self disclosure is a really hot topic in terms of building therapeutic alliance. If there's one thing that I've learned in third year, it's that countertransference is very real. And I don't mean that pejoratively at all. What I mean is like, I have a patient who I swear is my uncle. I have a patient who it reminds me so much of my parents, I think that it's just really drilled home that, I think the psychodynamics folks are really onto something there. And it can be really tempting because I have things that I want to disclose about myself that I think the patient would really connect with that would help me to build a therapeutic alliance. But I always have a really difficult time walking that line. What would you say in terms of how much self disclosure is too much self disclosure?
Oh my gosh, that's such a great question. And I think your point that, you could ask 10 different psychiatrists and they all might have a different answer really speaks to the nature of it. It's so individualized and what feels right for you and for different patient situations. And I think if you are constantly checking yourself and evaluating your own self disclosures and identifying some of that countertransference, like, oh my gosh, this person is my uncle, that can help guide the amount of disclosure that you do, just being aware of that kind of transference that's happening to make sure that it's not going too far in one direction or the other. So I think self-disclosure can be really useful in the right circumstances and really showing that you identify and can relate to patients. So I do primarily reproductive psychiatry. So I see a lot of mothers with young children. And, sometimes I'm mostly telehealth still. I have option for in person, but it's a lot easier for moms with little kids to just go from home. And sometimes the background can get a little chaotic, depending on what their older kids are doing or the baby's crying. And I can see my patients becoming stressed because that sort of this out of their control chaos around them and trying to get their kids set up with a show in the next room. But, and I will often disclose in those situations, I have a 3 and 1 year old. I get it. I know that they don't just because you're trying to do something does not mean that they're going to be on board with that plan. And so I do think that that helps them feel better about that situation. And I see them kind of relax. They're not trying to, oh gosh, what's this doctor thinking of me? I can't even get things together for this, you know, 20-minute visit. And so just sharing that about myself, I find really effective. And it's not something that's intensely personal. You wouldn't have to dig too hard to find that information out about me, kind of as a rule of thumb. So I will disclose some things like that. But if you couldn't find it about me in a quick Google search, then it's probably not something that I wouldn't disclose about, but kind of some of that type of, oh, I know how chaotic things can be with little kids, or I too love gardening, or those type of things, I think can really just help that personal connection. Ultimately, I think that's what drives so many of us into psychiatry is because we really enjoy connecting with people. And sometimes part of that involves sharing a bit of ourselves.
So, yes, to all of our newly minted doctors, your patients will Google you. Sometimes they will tell you about it. I had a patient, I got him from the waiting room and he told me immediately, I was just scrolling through your Twitter and he was like really deep. I think he was like years old in the replies.
Oh, well,
Yeah, it was really something. And that's a really good example about, I am a mom too. I have a 1 year old and a 3 year old. What a simple statement to really put someone at ease. Okay, this person really gets it. And that stands in contrast to a patient talking about how difficult it has been to lose a parent. And I say, oh, I understand how you feel. I lost my parent. In that case, that would be inappropriate. I think that would probably be more invalidating for the patient. I think that would hurt your therapeutic alliance. So, kind of choose very delicately, very carefully where you're going to self disclose. Another flashpoint I think that people have different takes on. And when I ask this question, I think about a part of Marsha Linehan, who's the creator of DBT. In her memoir, she talks about supervising a trainee who is just so boring for an entire intake. And she can watch the patient being bored. And the first thing she says to the trainee in feedback is, are you ever funny? So, what about the use of humor in an interview? Is there a place for that?
so I do think there is a use for humor, but I think it's similar to self-disclosure, and you got to be careful when and how you use it. And I think actually humor and self-disclosure both are something that you got to make sure you're using it because you think it'll benefit the patient, not because you think, oh, I have this great joke I'm going to say here, or, oh my gosh, she's talking about her chili recipe. I have the best chili recipe. I just have to share it. But really identifying like, will this help me connect with the patient more and make her feel more connected to me, or like she can share her story more easily, or help me get into this other piece of information that I need better. So really being mindful of that. So I'm not a particularly funny person, so I can't say it's a strategy that I am able to employ very well or often, but I have seen humor used very successfully in the right moment.
Sounds like it's probably something that gets a little bit easier with experience and patient volume. Okay, so general rule in psychiatric interviewing, we want to use open-ended questions. That's something that everybody should learn on the first day of their clerkship. But there are exceptions to that rule. It's not always the case. When would you recommend using open-ended questions versus more closed-ended simple questions?
Oh, I think it depends a little bit where you are in the interview, and I don't want to say open-ended questions are even better than closed-ended or more focused questions, but it really depends on what you're trying to do. So at the beginning of the interview, I try to be very open and we talked earlier about redirecting patients back to the content that I need. But at the beginning, I really want to give patients free rein for 5 minutes or so just to kind of say what they are feeling, what their goals are for coming in, and leaving it really broad. Why are you seeking care now versus, 2 years ago? What's been going on that brings you in? And that will be very different for every patient and oftentimes help establish rapport and get a good idea of how you want to direct the rest of the interview. But then also, I think, gives patients space to feel like they're going to be heard during this time. So in that regard, I generally start with more open and structure it that way. And then as I'm looking into different content areas that are important, I'll also start each content area with a more open question and then sort of narrow in to get details as needed. An example where I think this is really relevant might be for substance use disorder. Sometimes, you might ask a very broad question about it, but really in areas where patients are not inclined to maybe be as forthcoming with information or may have shame or embarrassment, it may require some more closed-ended follow-up just to confirm. I've had a lot of patients say, oh, they've never used any substances. Follow-up. Does that include marijuana? Have you ever used marijuana? And they haven't used marijuana regularly. So I think that also getting the open to get more broad strokes and then really filling in the gaps with those closed-ended questions. The other thing, as we're thinking about open and closed-ended questions that I see trainees do sometimes is, and I've been guilty of it myself, so I'm, no judgment from me. I think it's easy to get into. We'll be talking, you might have 60 or 90 minutes for an interview. You'll be talking with the patient. You may have followed them into some terrain or spent way more time maybe than you really had on a topic because it felt you're connecting good. It was very conversational. And then suddenly you look at the clock, you have been talking with this patient for 50 minutes and you got to go into your faculty, but you have covered, maybe a sixth of the topics that you want to cover. I think we've all been there. And then I'll see sort of trainees realize this and sort of pepper in at the end, sort of this mad dash rush of close-ended questions, trying to fill in all these gaps. And um, you know, depending on the situation, if you haven't, if you're worried about like suicidality or an immediate safety concern, that might not be appropriate. But in those instances, I think those close-ended questions can really sort of shut up rapport in the conversation and it just turns very checklist at the end. And I would advise trainees to really think about, okay, I have, 10 minutes left or 15 minutes left. I don't have time to cover all these topics. If I cover one more topic, what do I need to cover to at least get started on a plan? And it's okay to note in your formulation, like, spent more time on these topics today, will prioritize ensuring review of XYZ next visit. So people know you didn't just forget about it, but made that conscious decision with the time that you had. Especially as an outpatient provider, it's really easy then for me next visit. Hey, last time I know we talked a lot about review systems, but I had cut short, the ADHD screen, and I really just want to make sure that you haven't had a history of anything that would make me concerned for ADHD. So I just want to ask you a few questions about that. And, it's not urgent, especially if they didn't come for an ADHD evaluation, but there have been a lot of times when then people bring it up later and it's helpful in your intake or in a visit close to the beginning where you can say, yeah, you didn't endorse any of these tests. That was the first time we met. Um, and so, not being afraid to do that either and avoiding the cram of close-ended questions at the end.
Yeah, I think the pacing of the interview gets easier over time. You kinda get a feel for it that however long you have, that hour, that 90 minutes, it has a certain rhythm to it. We're gonna talk about a couple more broad considerations, and then we will actually walk through kind of a suggested structure for an interview. So rhythm and timing. How does rhythm and timing play into the clinical interview?
Yeah. So I think, again, it varies on where you are or what you're trying to do with the clinical interview. I think that's the toughest interview skill. Anyone can go through and make sure they get all the information if they have all the time in the world. But how do you do that in 60 minutes or 90 minutes? So that's where that timing goes in. And then also knowing what information may not be as important in that moment, and so how do you focus? To get the content which is going to most directly impact your plan and making those decisions is also where I think our clinical expertise and experience really comes in so that we can get the highest yield stuff covered. And I think a big part of rhythm is having some idea of how you want to structure the interview before, so if you're thinking about a 60-minute interview, maybe the first 5 to 10 minutes, sort of introduction, figuring out what brought them here, what they want accomplished, and then kind of moving towards really exploring the content. So psychiatric review system, family history, social history, those sort of pieces might make up the bulk of your, the meat of the of the interview, the stuff you're really going to use to help with your formulation and decision making at the end. And then the last 15 to 10 minutes sort of earmarked for patient education and getting that treatment plan in place and working with the patient to create a plan that will work best for them. So that's kind of a really broad strokes. I think the other important thing for that rhythm and timing is thinking intentionally about the transitions and how you can do those effectively without sort of going again down that wandering patient path.
And one of the things that we'll talk about in our psychotherapy episode is kind of the frame of psychotherapy and how it's really important to set up the relationship between the physician and the patient. And I think that goes for the psychiatric intake as well. So at the beginning of the encounter, I'll say to a patient, I always find it's easiest to gather some basic information about who you are and what your life is like. And then we will kind of dive into whatever it is that's on your mind. And what I'm telling them in medical speak is we're going to do a social history. We're going to use it to get some basic facts and build some alliance. And then we are going to dive into the more emotional topics. When we are doing an interview, we are gathering an enormous amount of information. We're gathering information from what they say. We're gathering information from their body language, from their affect, facial expression. Sometimes we're getting collateral information from a spouse, caretaker, the PDMP. And at times, this information can contradict itself. So I think of a patient who, how have you been? How's your mood been over the last couple of weeks? Oh, it's been great. And they just have a flat affect. They have psychomotor slowing. And then, the next thing they tell you about is their thoughts of suicide. And so their stated mood is not congruent with kind of how they look. When we're talking about all of this different information that we're gathering, how do you sort of categorize it and organize it in your mind before you go to document it and formulate it?
Yeah. So I think part of the challenge with interviewing is that you're hearing what the patient is telling you and you're making clinical decisions based on that. But then you also have to combine it with how does the patient look, what's going on. And sometimes I will, challenge gently, challenge you, just not in a aggressive way at all, but just, hey, you say that you're feeling really good, but you just seem, um, sometimes I'll even use the word flat with them. Or you just seem sort of down and maybe not as bright as you have in the past times when we've talked. Like, do you notice that at all? And sometimes just asking patients about that directly, I've seen be really effective into kind of digging into more. I think always with the psychiatric interview, especially digging down to the validity of what a patient is saying, even with patients don't have any ill intent, sometimes just sharing information accurately can be really difficult. And that can be because they honestly don't remember. There have been studies done, people who were hospitalized for mania. So obviously having a lot of manic symptoms when years later asked, any history of bipolar disorder or have you ever, asking about manic symptoms, they nope. People don't always remember. Well, especially if you're asking about things, they were having some pathology impacting their brain functioning during that time too. So remembering that and even even without mania or just details of life, people just really have trouble with recall for things that happened years ago, especially if you're looking at like the other thing that comes to mind with that for me is like ADHD as a child. I have people that don't remember what their elementary school's name was, let alone how they, what symptoms they might have had during that time. And so, asking questions in different ways that may help with the validity of information can be useful. And there's some different strategies for that, maybe out of the scope of, of this.
I think this is where cultural considerations come into play too, right? So in the United States, when you say, you might say just as a greeting, "Hey, how are you?" And the response is, "Good, how are you?" There's
Mhm.
a phrase that I like, "Don't tell your friends about your indigestion. How are you?" is a greeting, not a question, right? So as we're doing this interview, we may be asking really direct questions, but patients' responses are informed by sort of culturally dictated norms, and a lot can get lost in translation when we are not thinking that way. So we need to be very direct, ask clarifying questions when we need to. And then in thinking about documenting it, one thing that comes to mind is shout out to the Curbsiders Internal Medicine podcast, one of their dermatology episodes. They have a dermatologist talking about how to document rashes. And the dermatologist says, like, just write what you see. Don't write, this is a maculopapular rash. Don't write, this is a particular rash. Write, there are 1 to 2 millimeter small red dots that are slightly raised from the skin, and the skin around it is pale, and it takes up this much space. You don't need to over medicalize things because really the objective information is what we want when we're reading the document. So you can say in your note, the patient states that their mood is good. And then you can say in your mental status exam, the affect is flat, blunted, etc. And then in the assessment, you can put those two together and say, well, the patient says this, my objective assessment is this, and therefore, my opinion is this. Okay, so I want to bring up a couple of common difficult scenarios that come up in an interview and just kind of get your expert opinion on how you would recommend dealing with them. Because this is really intended for people who are starting their residency, who are going to encounter these situations day to day. What do we do when symptoms distract from the patient's ability to engage in the interview? So, for example, if you spent time on the inpatient unit, you can think about a patient who has a primary psychotic disorder, maybe a type of syndrome that we would call florid psychosis, where they have thought blocking. You ask a question, they begin to answer, and then you can sort of watch them, what looks like staring off into space, and we would call that responding to internal stimuli. And so those symptoms are really getting in the way of our interview. How do you deal with that?
Great questions. I think, again, kind of pulling away from the, we need to get every single piece of information before we can make some clinical decisions. And so if I have had interviews with manic or psychotic patients, or even patients who just, I'm thinking about an interview clear back. I don't do child, but I was on a child inpatient unit during residency, and sitting with the patient in silence for probably 15 minutes before they were willing to talk with me. So giving patients space, if that's sort of the scenario, and giving time. I wasn't concerned with her about a psychotic process based on other factors, but giving, I'm here, we'll sit and talk about this, and not, you can be quiet for a few minutes. And it was, just to clarify, I did non-threatening manner, and it wasn't like I had come back and given her space and set that up. But with other types of symptoms impacting, and you're just not going to, no matter how long you sit there, you might not be able to get a good interview. It's okay to kind of really focus on, can you get consent for treatment that may help move the interview forward in the near future. So that's one thing. And then the other thing is being okay getting maybe less information, getting collateral information. But also, I say that with the caveat of, don't give up on the interview. Sometimes I think we've all entered situations where, like, we're not going to get anything. And then you try it and you go, and you're able to get a pretty darn complete interview when you didn't expect, because someone does have a lot of psychotic processes. So my takeaway is, don't assume because of pathology that you won't be able to get a good interview, but don't feel like you have to really force it if it's just not working. And think about using treatment options to help then get the patient to a better frame of mind, be able to get a more thorough interview at a later time.
And just because the patient's not giving us direct answers to our questions in the way that we expect, sometimes that in and of itself is really pertinent information to document and to inform a treatment plan.
Yeah, and especially get an idea of what their psychotic process would that look like for this patient.
Okay, here's another tough question for you. How do you recommend dealing with it when we perceive that the patient is either intentionally or unintentionally deceiving us?
So unintentionally, sometimes, I guess in both cases, I will gently challenge the patient. So if the patient says, "Oh gosh, I haven't," thinking of a patient I had yesterday asking about self-harm thoughts. She was having some thoughts of self-harm, but hadn't self-harmed for many years. Like, how long ago do you think it's been since you self-harmed? And it's, oh, at least 10 years ago. Okay, so you would have been in high school at that time. Have you self-harmed since high school? And, oh, yes, she had. So it, then kind of highlighting, okay, well, that time frame of 10 years doesn't fit, and I don't think that she was intentionally trying to mislead or extend, because there's it still seemed like she had a pretty significant period of being able to avoid self-harm, thankfully, but, so really sometimes locking in on different specifics that may help the patient remember a little better. So versus like a time frame, but really specific, like, were you in high school at this time? Were you living in Omaha at that time? And that can help ground patients a little bit better. Other ways that you can sort of ground is like, were you um, in the relationship with so and so at that point? And that can also help give a timeline a little bit, or connection. Were you having these symptoms, before your daughter was born? When asking about sort of time frame of things, where I think people unintentionally can get pretty off base, grounding in some of those life events, I think can be really helpful. Also, for unintentional assumptions, if someone says, I'm sleeping horribly, asking some clarifying statements of like, well, what time are you going to bed? What time are you waking up? Oh, it looks like that's about, 7 hours. For most people, that seems like it would be an okay amount of sleep. Do you feel like that's just not enough for you? And then actually, I guess, yeah, I'm okay. So really just asking some clarifying questions can be really helpful.
I mean, that happens all the time. That exact example happens all the time. And I think sometimes patients have a lot of self-consciousness about not remembering every detail of their life. They especially maybe type A people who come to a psychiatric interview, they want to remember everything and tell it to you exactly right. And I think gently reminding the patient that, it's really not going to change my management if your last drink was 25 years ago or 7 years ago. I just need a ballpark figure here. For psychiatric hospitalization, it's not going to change my management if you were 10 years old, 13 years old. Just kind of roughly guess for me and encourage them that it's okay to be wrong.
Yeah, and tell them I'm not intending to quiz on your life. Where I see patients tend to get really nervous like that is remembering past meds, which actually might change management, unfortunately. And different things too to try to get some of that information. You can try like listing meds. Sometimes that will help folks recall, oh yeah, I have been on Prozac. Sometimes it's, well, I don't know, I've heard of that one before, but can maybe give a little peek of insight.
So what about this intentional deception, Dr. Raml?
So a lot of times it depends on why I think they're intentionally deceiving me. So if I think it's sometimes I'll have patients who are really just seeing me, I think, to get forms off work or things like that, and really challenging. Why are you needing this time off work? It seems like you're able to do XYZ really effectively when you're not working. I see that you're now babysitting your granddaughter instead. And usually, if someone's at that level where they're able to function in the care of a family member, they're probably able to be working in some capacity. And so, not necessarily pointing out to them like, hey, I think you're lying or I think you're abusing the system. I wouldn't presume to say that to anyone. And I wouldn't assume that I always assume positive intent with people, I think probably more than I should. But even just challenging some of those discrepancies of when I think someone may be misleading for some other gain or something, just challenging them on that. And, really, I think you also have to be careful because if you kind of push too much on things, then patients won't be forthcoming. So if I say, well, if you're not working, like, how are you watching your granddaughter? Then maybe she doesn't share that she is watching her granddaughter regularly the next time we talk. So it's a delicate balance so that you can still get the information to identify these things, but then also challenging the patient on that.
Of course, we always have unconditional positive regard for our patients, and I think to inject some empathy here, to some degree, deception is normal. I hope that's not a hot take. People deceive other people to get what they need, and oftentimes, that can be maladaptive and can lead to problems down the road, and can not be very pro-social. But other times, it's totally normal to, deceive someone, tell a white lie to get out of something that you don't want to do. I think that's actually a developmentally appropriate response. So deception is something that we all engage in from time to time, and we need to have respect for that and realize that our patients have needs they want met, and that just makes them human. That we all have needs that we need to get met, and we get them met in the best way that we can. Another thing that I will do sometimes, and I picked this up in the forensic review course this summer, was if a patient seems to be endorsing every symptom, This is particularly a patient who's really suffering. Maybe they just got admitted to an inpatient unit. They feel like their life is spiraling out of control. And it seems like every symptom you ask them, they are saying yes to. This comes out a lot when you're screening for mania, which we'll get to in a second. And, you're asking the patient, are you more, during these periods of elevated mood, are you more distractible than usual? Yes. Do you have elevated energy? Yes. Is your mood elevated? Yes. And you think, I think they're going to say yes to everything that I say. Well, then you might ask them, during these periods when your mood is elevated and you have a lot of energy, do you actually feel like you're thinking so clearly that your thoughts slow down? And they say yes. And you can say, okay, good. Then they don't have racing thoughts, right? So you're kind of reading a patient, seeing where they're at with things and adjusting your interview accordingly to make sure that you get the most accurate information possible.
That also kind of, as we think about if I think someone's intentionally lying, you can phrase questions in, pepper in some questions. Your comment on mania, do you ever think you're so clearly that your thoughts slow down? But if you're worried about someone like mimicking psychotic symptoms, do you ever feel like the voices are slipping in under the door? Is something I've heard used. Or do you ever see people's thoughts spelled out above their head or something like that? And you don't want to do all of those because too much will seem fakey, but incorporating some of those questions in can help kind of okay, there's something that's not consistent with what we typically would see in a psychotic disorder.
Brilliant. And in both of these cases, it's not that we're trying to trick the patient. We're trying to get the right diagnosis so that we can get the right treatment. And I think in either one of these cases, the patient's not sort of lying for secondary gain, maybe, but just really suffering and just really wanting someone to understand what they're going through and help them. And so we need to use our expertise to work with whatever it is that the patient brings into the room. Psychiatry Boot Camp is brought to you by Simple Practice. Are you thinking about starting your own practice, but you're too daunted by the business and logistics? Or maybe you have a practice, but you're spending so much time on scheduling, record keeping, and billing that it's burning you out and slowing you down? Simple Practice is the solution for you. Simple Practice is an all-in-one EHR designed to help practitioners thrive. From admin work to clinical care, Simple Practice has a suite of tools that work together to simplify practice management. This includes e-prescribing and PDMP checks integrated within the app, and a lab slip template that can be easily sent to patients within the portal. With Simple Practice, you can spend your time on what matters most. For an exclusive 7-day free trial and 70% off 4 months, visit simplepractice.com/bootcamp. That's simplepractice.com/bootcamp. Psychiatry Boot Camp is brought to you by Beat the Boards. I am so excited to have Beat the Boards as a partner because this is the question bank that I used to study for my own psychiatry board exam, and it made the exam a breeze. The Beat the Boards question style was so close to the style of questions on the real exam that I felt over-prepared during the test. Beat the Boards has courses in psychiatry and virtually every other area of medicine. Visit beattheboards.com to view the entire catalog and take advantage of Psychiatry Boot Camp's exclusive additional 10% savings by entering the word bootcamp in the referral line in the shopping cart. Again, unlock these additional savings with referral code BOOTCAMP. That's one word, no spaces, bootcamp. Okay, so now having gone over some sort of foundational principles of the psychiatric interview, let's go ahead and move on to how you would recommend we structure it. I think this would be easier if we had a whiteboard, but let's try it via just podcast here. Could you walk us through how you structure the psychiatric interview?
I'll try avoid being too redundant from what I said earlier, just about sort of the intro, 5-10 minutes, sort of why you're here, get to know you, set the framework and boundaries. And then for me, really getting into the psychiatric view systems, I think that's another area where I see trainees maybe not be as thorough on that and get more hung up on minutia of social history, which is sometimes more interesting and also very important. So I don't want to minimize that. But the psychiatric review systems is really where it's at, in my opinion, for the psychiatric interview. And so really collecting symptoms on mood disorders, anxiety disorders, psychotic disorders, PTSD, and then other ones that I personally have incorporated in just because I've found when I don't, it comes up later and um, I've now made it a practice to ask about these at the beginning: ADHD, borderline personality disorder, eating disorders. And then also, just as a note, if you're not covering kind of OCD symptoms when you're thinking about anxiety disorders, panic disorders, OCD needs to be in there as well, in my opinion. And that picture will really help make sure that you're not missing something more. Patients will often come telling you XYZ symptom. They think they have diagnosis of anxiety, but really on teasing out, maybe it's better described by PTSD, or maybe it is better described by OCD or ADHD. I would say most of the referrals I get from primary care are depression or anxiety, but that's not probably still the majority of our diagnosis because it is the, most common psychiatric diagnoses, but the ratios are very off, I'd say, from what I end up actually diagnosing people with and what they initially come to see me for. So really stressing this importance of the good psych review systems.
Are you starting with the HPI and psych review systems, or are you starting with the social history?
So that's a style thing. I personally like starting with the psych review systems. So I guess a couple of things on that. Generally, I find in my HPI, I also touch in on what's weighing heavy on you. What are your supports and strengths? That's part of just my general what brings you in, kind of getting the lay of the land. And oftentimes, any really pertinent social history will reveal itself there. I'm fighting with my spouse all the time. I am going to lose my housing. I am struggling with infertility, whatever it is for that patient. That a lot of times will come up when asking, if for me, and that's part of my HPI, like what are some things that are weighing heavy on you? So then it takes a little pressure off my social history. And so if I do end up expanding something in the review systems more and getting crunched for time, I'd rather have that time weighted on the review systems and the social history. And I know, you mentioned earlier, and I have seen a lot of people do that really successfully. They almost start with the social history as like a little bit of a get to know you. And I think that it can really work well there too. And I think that's also one thing I really love about psychiatry is it's a field that you can really add your own take on it and find something that works for you and still be within evidence-based guidelines and best treatment practices. And it's going to look a little bit different for everyone. And that's fun to me.
One thing that I really love about psychiatry is how different it seems to me than really any other medical specialty. Sometimes I feel like the odd one out in psychiatry, and I actually kind of love that. So one example is this HPI, right? In every other clerkship that I went through, I was using this old carts, far colder mnemonic, right? Frequency, onset, et cetera. You all know that better than I do to take the HPI. But in psychiatry, you're asking some of those questions, but really the initial open-ended questions about why you came in, and then the psychiatric review of systems kind of replaces that history taking. And to your earlier point, sometimes the chief complaint will be, "My life is falling apart," or "I'm getting a divorce and I can't handle it," or suicidal ideation. But then when you really do the review of systems, you find that there is an underlying diagnosis that is contributing to the chief complaint, and that's kind of our job, is to tease that out. Can we delve into the psychiatric review system? So I think this is really difficult to conceptualize to people who have not spent time in the field, because we have a very daunting task of taking the human condition and putting it on paper. So, we have these different sort of families of disorders in psychiatry that we break up symptoms into. Can you walk us through those families and maybe a little bit about how you screen for each one?
Yeah, great question. So I think as a really, really broad strokes, I think about mood symptoms, psychotic symptoms, anxiety symptoms, and then personality disorder symptoms and other. So mood, depression, and mania. So asking one or two questions that'll help elicit, do they have a history of mania? I think of myself as a medical student. I would try and ask, have you ever had a time when you felt on top of the world and everything was going really great? And patients would almost always say yep. So it was not a good screening question because even someone without bipolar has had, you know, they went on a really fun family vacation or they had a really awesome wedding weekend or whatever it is. Most people have had an experience like that. So I quickly learned this is not telling me anything I need to know to help the patient. Now I ask people, have you ever gone a period of several days without sleep and felt like you didn't even miss it? Or maybe you just had really minimal sleep. And that occasionally I'll catch people who, oh, it was finals and I was so tired, after I finished, I just crashed. But usually that's a pretty good tell if someone answers yes to that, it perks my attention and then I can get into the rest of those mania symptoms. And here's where I think having a good handle of the DSM criteria can be really helpful. So when you have that, okay, ding, 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 I need to look into this more. You can go straight into some of those DSM 5 criteria, which will become rote in your mind if they're not already, so then you're asking about distractibility, grandiosity, flight of ideas, thoughtlessness or impulsivity. How long did it last? And then it can really give you a clear picture of, oh, yeah, they meet the mania criteria, being bipolar disorder. Here we go. And similarly for depression, a lot of people have periods where they're feeling down or sad, but what is this really? Well, does that really meet depression criteria? And kind of asking questions that are really specific to like a major depressive episode versus just the human experience. And then if you are getting into that, then getting the rest of the Sigmy caps kind of checked off and through and exploring that.
So in our mood disorder bucket, we are screening for mania. We're screening for a major depressive episode. Got it.
Yeah. And then kind of shifting then to if you're thinking about the bucket of psychosis, it's your mood disorder may help in your diagnostic structure. Um, once you put that with history of psychotic symptoms, you're thinking about like a schizoaffective disorder. So asking about paranoid thoughts, do you feel unsafe in your home? Auditory or visual hallucinations? Do you feel like your mind's ever playing tricks on you? Do you feel like you're ever seeing things that other people don't or hearing things that other people don't? Thought insertion and thought broadcasting are also things that I think if you're suspicious or if something just isn't quite, you're using your clinical intuition and you're just concerned for psychosis, asking about some of those additional types of psychotic symptoms can be helpful. So, do you ever feel like someone's putting thoughts in your head that aren't coming from yourself? Do you ever feel like other people are reading your thoughts so you don't want them to see? And then, kind of the last of that piece, the ideas of reference. Do you ever feel like you're getting special messages from the radio or from a TV show that has particular meaning to you? And sometimes those can, people who can present fairly well, and then you'll get into some of those questions and have pretty significant, it can reveal pretty significant psychotic processes going on. And then the other thing with psychosis, as you're screening for that, thinking about thought disorder. So things just not quite clicking right, that thought blocking that you mentioned earlier, Dr. Mullen, and just this sort of disorganization. So being kind of alert to that, that'll usually present throughout the interview as some of the other psychotic symptoms might, or manic symptoms too, but that disorganization that may also tip you off to a psychotic disorder.
Okay, so that's our mood disorder bucket. That's our psychotic disorder bucket. And then what are the other buckets that we're screening for?
So then I'd also think of like anxiety type symptoms, which depending on, with how you want to think about it in the DSM, but more just conceptually for anxiety disorders, thinking about social anxiety, panic disorders, sometimes phobias, plus or minus. And then also for me, that's where I conceptualize asking about OCD and intrusive thoughts, and then also symptoms of PTSD. I've heard different psychiatrists have different opinions on when or how much you should be exploring PTSD diagnoses, whether the patient's ready to handle it. Are you ripping the Band-Aid off and then sending them out into the world if they have suppressed past trauma? Usually I ask something more general and are you having any problems with nightmares? Um, is that related to a past trauma? Or are there any places that you avoid because they bring up bad memories? And then if I feel like it's appropriate or if I feel like I have that rapport built up getting into that past trauma, and also creating a safe space, telling the patient, with the trauma, I'm happy to talk about this in more detail if it's something you feel like would be helpful. I also want to make sure that we have the space and you're feeling emotionally prepared to talk about it. So we don't have to talk in more detail if you're not ready at this point, and giving them that, hey, I'm here, but this isn't something we have to go deep dive in, which can be really traumatic for folks to do. And that also can vary a lot on clinic setting. So that may look a little different in the PES if you're seeing this person once and probably not going to see them again versus if you're in an outpatient clinic and planning on having a long time working relationship with this person.
So that's our anxiety disorder and PTSD sort of bucket. And of course, PTSD used to be classified in the DSM as an anxiety disorder until recently when they pulled it out, I think in DSM-5 and gave it its own
Mm.
category as trauma and stressor related disorders. And another really good point, we are asking really personal questions, really sensitive questions. Point very well taken. It's not the goal of the psychiatric interview to have a patient come in and unpack all of their years of horrific trauma on you. That is not helpful to the patient. It can be harmful to the patient. So we need to set up these questions. So you might say something like, this question is intentionally broad and it's really personal. and it can be really difficult to talk about. But I just need to ask you because depending on your answer, it will inform our treatment plan.
Mhm.
And you're welcome to tell me as much or as little as you feel comfortable telling me. And then you go ahead with the question that you mentioned, something like, do you get nightmares or do you have exposure to violent or traumatic events of your past that are still giving you problems today?
And then the other piece of that really valid if a patient does share, then when you are going to the treatment plan, coming back to that and validating, hey, this is where that, don't bring up, but hey, because you were so open to me today, these are some of the recommendations that I might not have had otherwise. So I know as trauma therapist, I can place a referral or, these nightmares sound really horrible. I think we should start medication for nightmares for the patient. I'm really highlighting, hey, this will really help with that nightmare. So then it's not like they just told. I think patients sometimes, especially people who are in therapy and mental health treatment more long term, they start to feel like, oh my gosh, I can't tell one more person my story. But if it's, hey, this is what I'm able to help you with because you were able to share, kind of highlighting that for them.
Really important psychoeducation piece there. When you're kind of beginning to educate the patient on how the body responds to trauma, the treatment model for PTSD and PTSD symptoms, you are taking some of the burden off the patient. You are providing some psychoeducation on what that is all about. And you're reminding them that their job is not to unpack all of this, which might involve re experiencing it in their mind. You answered this earlier, but I'll just kind of recap. So, you think that it's a good idea to ask all patients about their relationship with food, OCD type symptoms, ADHD symptoms. Is that right?
Yeah, I think that's OCD, you could lump into anxiety pathology. But yeah, I do think it's important to ask about that. And then also ADHD, eating disorders, and borderline personality disorder, particularly. Personality disorders in general, yes. But I think, most commonly, some studies show, 20% of patients in an outpatient psychiatry clinic could meet criteria for borderline personality disorder. So if we're not screening for that, we're what are we screening for if it's something that 20% of patients might have? I'm always surprised that that's not on more psych review systems.
On your point about the screeners, of course, the clinical interview is the gold standard for making a psychiatric diagnosis. You need a full, comprehensive clinical evaluation to make a diagnosis, but that doesn't mean that screeners aren't valuable. So sometimes you can spend 45 minutes parsing out the history of mania because you just can't seem to get it straight. And that's where you might consider administering an MDQ just to give you more data. Or if you are perceiving some cluster B traits, you might consider giving them a clean screening instrument for BPD. We have these screeners and they are very helpful to aid us in making a diagnosis. They do not make the diagnosis, but these are really useful. You can use them very liberally with your patients. You can administer them in the waiting room. You can give it to your patient at the end of the visit if you just don't have enough time and ask them to fill it out and give it back to you and kind of include that in your documentation to have some objective evidence of your diagnoses.
Definitely. I think if you're not using screeners, you're missing out on a great tool in our toolbox as physicians and clinicians because they can be so helpful when you're at that point where you're like, I could kind of go either way. I'm going to make this call because this is what I think is best. But here I'm going to just, um, not that I would do screeners just to confirm what I'm thinking, but it can help with that. If I'm on the edge of something, may help with that clinical decision making.
Okay, so that is our HPI, which is sort of the psychiatric review of systems. Is that right?
Yeah, sort of the background and then, yeah, that's like previous systems. Yeah.
Moving into past psychiatric history, what do we want to know when we take a past psych history?
So for me, I want to know, have they had any psychiatric diagnoses in the past? Not that I'll always keep them because that's part of me doing my own thorough psych review systems because I trust my colleagues implicitly, but I just want my own confirmation. But it is helpful, if I'm thinking, oh gosh, it sounds like that might be mania. And then I say, oh yeah, I've been diagnosed with bipolar 1 before. That can also help me a little bit in my decision making. Other things, outpatient providers is another thing I'm going to want to know about. Every patient I'm seeing, do they have a therapist? Are they going to any support groups? Or do they have a community support worker? Who their primary care is? That type of stuff can be really useful. The other thing that is really important, I would almost say, not most important, all of these things are important, but previous hospitalizations, that can give you an idea of the patient's level of functioning. If they're hospitalized, 3 times in the last year, that's a sign that things are not going well for this person. Or if they have had a history of, oh gosh, in 2005, I was hospitalized 3 times. I haven't been hospitalized since then. It lets me know, gosh, this person has a history of things really not going well, but has the strength of this sustained remission period. And how can I build on that? But also kind of alerts me that, you know, I don't want them to relapse with more severe symptoms and they have a history of being really sick. And then previous medications, therapy, like different psychotherapy modalities that they've been tried, other non-medication or therapy-based interventions like ECT or TMS, those types of things help let me know what the patient's already been on, so I'm not, reinventing the wheel. If, "Hey, when I started to experience more manic symptoms, this was really helpful. Um, I don't need to rediscover that. Let's go with what worked for the patient in the past." But then also, if they had a bad side effect or I just did not tolerate this or this wasn't helpful, then we're not going back to something that's just gonna waste our time and keep the patient, maybe not doing as well. And then from a risk perspective, we also wanna make sure we're getting any prior suicide attempts or prior self-harm attempts, and then, of course, any ongoing thoughts or discussion of those. If that hasn't come up, or if they weren't endorsing, suicide ideation or self-harm when you're doing that psych review systems.
Okay, so for the past psych history, we've got hospitalization, suicide attempts, prior therapies, either meds or interventional, outpatient providers. Moving into the past medical history, what kind of things do you want to know in the past medical history? Is there anything in particular that you want to ask about?
Yeah. So, of course, you want just general medical history if a patient has chronic renal failure or something that may impact your medication. So, you got to be mindful of their overall medical history, of course. But the things I really focus in where I see the greatest impact directly onto psychiatry are a history of head injury or TBI, seizure history, thyroid problems, headaches, chronic headaches, maybe an indication of different psychiatric pathology, strokes, or any like autoimmune encephalopathy or really any medical conditions which are gonna impact brain functioning.
So there's your past medical history, and of course, a lot of that we can find in the chart. Sometimes you'll ask a patient their past medical history, and they will have quite an extensive one, and maybe they just won't kind of remember it. So we can use the chart to inform us of that, and then just kind of check with the patient. Hey, here's what we have in the chart for your past medical history. Is all this right? Do you have anything to add? Okay, and then the other thing we want to ask every patient about is the family psychiatric history. How do you ask about that?
Yeah, so that's not one that I have great transitions into, more just, "Hey, I really want a complete background of who you are and any genetic factors which may be impacting you. Do you have any family history of a mental health diagnosis?" And then so that I guess, as harkening back to our earlier, like, broad and then narrowing questions, a lot of times people will give you sort of mixed response with that. And then asking about completed suicides because that can be a specific risk factor for suicide in your patient, and then substance use, because a lot of times people don't associate substance use with other mental health diagnoses. I find that can also be a really nice transition to their own substance use history. So, okay, so your father suffered from alcohol use disorder. Do you drink alcohol now? And then can move that into my substance use history as well. I think that's another sort of style thing. I wouldn't be surprised if people start moving substance use more to the review systems in the future. Historically, and when I trained, it was kind of conceptualized under like social history, like a bigger block of it. But really, I think at its core, it is psychiatric review systems and something that, although I didn't mention it, my review systems, definitely something we want to be screening for in all of our patients because it can have such a big impact on their presentation. And if you're missing significant substance use, you can likely have the wrong diagnosis.
Right. So substance use disorders are quite heritable, as we know, and they are quite biological. So I think that that makes perfect sense that it would not be such a social environmental thing as a true bona fide independent psychiatric diagnosis that would belong in the review systems. That's a really awesome point.
Yeah. So if you're not doing it in the review systems there, I think there is some shame attenuation effect that happens if you can link it to family history, because then it sort of highlights that for the patient of, well, this makes sense that I'm struggling with this. So I think that's one benefit from kind of transitioning from family history to substance use disorder.
Brilliant. Okay, so now the social history. This is the fun part. I like to spend time on the social history. I think we're really spoiled in our career to get to take a social history from so many people. I mean, how many different life stories we hear and we learn from. So, like, Just an example, last night I had a friend over who was talking about difficulties that he was having with his landlord, the people above them, the pipe burst, etc. And
No.
I started spewing something about well, I'm pretty sure that if you break the contract, this is how it works. And he was like, what are you even talking about? How do you know that? Why do you think you know that? And the answer was because I've heard it from, 20 patients that have told me about their current situation with their landlords and how that's working out legally. So this is a really special part of our job to get to know what people's life is like and what's important to them. So how do you take a social history?
Yeah, so I agree with you. First off, just the social history is so fun, because that's where I feel like you really get to know who people are and how all these symptoms impact their life and kind of what does the information look like for them. So, kind of broad strokes step back. I like to know start with, like, where were people born and raised. I like to ask people who raised you, and I intentionally leave that broad because sometimes people will come from a lot of different backgrounds, or maybe they were raised by their grandma or somebody else. And so then that helps to eliminate some of the stigma that might come if you're just like, oh, then if your next questions of like, oh, were your parents married, divorced, or were you raised by both your parents or things like that, which can have inherent stigma. So keeping that question broad, who would you say raised you? And also gives you some sort of insights into maybe their parents were happily married, but their grandma was really involved and she lived a block away and they went to her house every day after school. And then she'll get a nod there too. And that um, can be kind of nice because you know, okay, that might be another person who could be a support person for this patient if they hadn't mentioned them earlier. Then in a perfect world, I'd want to know a little bit more about their childhood dynamics. Did they have any siblings? What was their household like growing up? Were their parents employed? Or was that maybe always a stressor and a sign of a chaotic house? If their parents had a lot of substance use disorders, maybe they weren't able to hold steady jobs, and then the stress of that on the patient as well. And then how did school go for them? And how far they went in school. I like to frame it that way versus like, oh, did you graduate high school? Because then if they didn't, then that's hard. If a patient has a GED, I do ask kind of what was going on that you decided to go the GED route versus a traditional high school schooling path. Because often that can reveal that's not the standard path. And so sometimes that can reveal some interesting insights into their past and different things that might have been going on at that time for them. From there, I go on to their employment history. Usually, this can get all jumbled, depending on the flow of where the patient takes us in the social history. That's one place I do let them wander a little more. So, their employment history. Have they worked in the same type of field? Is this a more of a job or more of a career for them? What's their longest held job? I can also just help give you a little bit idea of how they're functioning. If there's someone that is changing jobs every 3 to 6 months, that's a sign that maybe there's some tension there. Maybe they're having difficulty in the workplace, maybe because of psychopathology, maybe for some other reason, but something I want to explore a little more. So then once you get an idea of employment, which can tell you how they're functioning in job relationships, you can also segue that into relationships. Are they currently in a relationship? And then if they say no, asking about past relationships. I leave that broad because I have had patients who, no, I'm not currently in a relationship. I broke up yesterday of this relationship of 5 years. And so that can be really telling to their current presentation as well. And patients may not share that if you don't kind of ask that detail. But I intentionally leave it broad though, because I have had patients who've never been in a relationship. And so leaving that broad gives them a safe space. I feel like, all right, I try to make it a safe space where they can say that as well and not have shame associated with that. Like, when was your past relationship? Well, I've never had a relationship. That can be not great either. So,
And of course, we're tailoring this to the patient's life phase, right? I'm going to ask every 19-year-old patient about their relationships, who's important to them, their intimate relationships. And I'm probably not going to ask every 92-year-old, so what do you do for work? That question
yeah.
might be, how do you support yourself month to month?
And what are they doing with their time? So, if someone's not employed, that I really want to know a little bit more. What's your day to day routine? Because if people don't have structure, a lot of things can fall apart. Maybe they need to get into some more volunteering or day programming or something like that to help provide that if they're not able to be employed.
How do you spend your days? That is such a telling question.
Mhm. And then, so relationships, and then from that, if you feel like more detailed, helpful, marriages, divorces, and the time frame of that, children that they have, also clarifying the relationships of, especially if their children are under 18, are they still with the father, or is that dynamic something that could be stressful? Um, because he never is paying child support, or it's always a mess on who gets what for scheduling, or he has different boundaries. And so that can also I've found that important often enough that I try to ask about that.
One question that I've worked in is, who's your biggest supporter in the world? And this looks a lot different. If you ask a 14-year-old, hopefully they would say the person who is raising them. And if you ask an adult, oftentimes they'll say their spouse. If they don't say their spouse, I think that gives you good information, just kind of getting an idea of what their life is like. What about religion and spirituality? Are you talking about that with every patient?
I try to, just because I think it can be a source of strength for patients if they do identify with a certain religious identity or strengths. But you have to be careful. It can be a two-edged sword. I've seen that people also come with some religious guilt if they feel like they are maybe were religious and no longer religious, or if they come from a family background which is very religious and they're starting to separate from that a little bit. But I haven't. So for all those reasons, I think it's telling. Or if they're happily a member of such and such church, when they start to not doing good, hey, are you still going to church? And church is also, for some of my patients who don't work or have a lot of family, church really provides a really robust support network. And so that's helpful for me as I'm trying to lean in on that and trying to engage the patient and boosting up or utilizing their supports, knowing about if they have that community connection and able to leverage that.
And
It's
I
helpful.
will editorialize here. I think that as demographically the United States, fewer people are identifying with an organized religion. And so the types of problems that you used to go talk to your spiritual leader about, sadness, feeling low, feeling lost, lack of direction, kind of existential problems, we're having more people seek mental health care. So I think this is an area where psychiatrists really need to be versed, is sort of spirituality, belonging, meaning, purpose. And I think, yeah, it's important to touch upon because for a lot of people, it is the single most centering force in their entire lives.
Yeah, and this is sort of an anecdote. I don't know if you want to include it or not, but I recently led Jean Tween. She's a sociologist. Her two main books are Generation B on millennials and different data around that, which I read in college as a millennial. Did not love the book. I thought for different reasons, but very interesting ideas. But then she recently had iGeneration. It's her newer book on Gen Z population, or she's coining it I generation. But she makes the point that that generation are millennials are more likely to say they're spiritual, but not aligned with a particular religion, but still identify with a spiritual connection. But Gen Z doesn't really. They don't identify as spiritual anymore either. So there's a continuing downshift. And what will that look like? And how will that impact these folks as we think about the biopsychosocial spiritual model people are are moving, and I don't, not saying that in a judgmental way, but how will that impact that sort of as a component to who people people are if people aren't really identifying with that?
Oh, completely. It's a complete social shift from where things were 50 years ago, 100 years ago. And we'll get into this in a couple of our other episodes as well, kind of how we need to be comfortable operating in the spiritual realm. Let's round out the social history. What other areas are you for sure screening for?
Current living situation, who's in the house? Do you feel safe in the neighborhood? Do you have any pets? And is it a stable situation? That I think really sheds a lot of light on things. And then sometimes plus or minus, I'll ask about legal charges, jail time, prison time. I think it's kind of stigmatizing to ask that unless you have a specific thing that you're searching for. So if you've noticed some antisocial traits earlier and you really want to flesh that out more, or they have significant substance use history, that can give you another idea of what sort of problems is a substance use disorder causing for this patient. But I might not ask that of every patient if I didn't have something specifically I was trying to assess for.
Right, like if you're seeing a patient for a consult in the hospital for capacity, you don't necessarily need to
Yeah.
ask, have you ever been incarcerated?
Yes. And the other thing I like to ask is hobbies, just because it gets them thinking about stuff that they like to do for fun. And then too, I'll file that away if they're ever not doing well. I can pull that up of, hey, could you start a new knitting project, or could you carve out an hour every Thursday night to do the XYZ, and helping with some of that activation planning later if needed.
And you had mentioned that you take the HPI and ROS first, and that oftentimes that will give you a lot of information that you would be asking about in the social history. And here's where I will give you the reciprocal, which is when I take the social history first, I always ask patients, what brings you joy in the world? And they might say a hobby. Oftentimes they'll say, gosh, that's a really good question. Nobody's ever asked me that. Well, I don't remember the last time I experienced joy, right? And boom, then there you've got your anhedonia. So I think asking about, self-care, hobbies, that can be really revealing as to what a patient's day-to-day life is like and how well they prioritize themselves and care for themselves.
Yeah, definitely. And can be a sign, I'll have patients maybe with chronic depression or like a persistent depressive disorder, but now suddenly they are no longer taking those self-cares or they're not showering or something like that. And so that can be a red flag to me. Also recently read an article for the MOC credentialing that was on substance use disorder. And the authors made the point that in their experience, kind of decreased self-care was the first sign that someone was moving towards like a relapse risk for substance use disorders. So take that for what you will, but
Yeah, I don't ask. I wasn't asking every patient about ADLs, but then a patient the other day said something about I'll shower more often. And I thought, I don't even ask my patients how often they shower, and the answer was like once every 2 weeks. So I think asking some of these questions, they can escape us, but they're extremely revealing. Anything else we need to make sure we ask about in the social history?
I think if you have all that, you'd have a more thorough history probably than in the chart before before you saw the patient. And then of course, you might think of any patient might have another couple things that are relevant and unique to them. So being open to the fact that there might be more stuff and that's okay.
Are you asking every patient about firearms?
Yes. Not so much in social history. I more do that with my safety assessment. Kind of as a if they haven't otherwise endorsed homicidal thoughts or suicidal thoughts or psychosis throughout the earlier parts of the interview, I'll just add a question sort of at the end with a more blunt transition, but just a statement of, hey, we're about out of time. I really want to make sure we have time to talk about what I think's going on here based on all this great information that you've been able to share with me today and get to what are our next steps to get you feeling better. But before we get to that, there's a few questions I just want to make sure. And so there, sometimes I'll, if I haven't already had the chance to ask about firearms, then I'll just ask it there.
Dr. Raml, you have been very comprehensive for us. I think everybody who listens to this will have a good idea of kind of how to go about the psychiatric intake. Is there anything else you want to make sure you tell our audience before we wrap it up?
Just that you get better with time. And even I think really experienced interviewers can still have roadblocks or interviews or just will think, gosh, that just did not feel like the flow was good. So don't get discouraged. Just keep at it and know that you're doing good work in a great profession. And I'm so glad that you're interested in it and listening to this podcast. The other kind of thing for anyone who's interested in more information on just interviewing in general, one text that I found pretty thorough and to be of good quality is Psychiatric Interviewing, The Art of Understanding, and that's by Sean Christopher. So if anyone's itching to really dig in more or read some text on it. Today was more about the basics, but there's really a lot of nuance that can be had as you get into more of that advanced interviewing level. So
You're reminding me of that Maya Angelou quote that people will forget what you said, they'll forget what you did, but they'll never forget how you made them feel. And so I think if you go into an interview with genuineness and seeking first to understand, you can make missteps and it will be okay. Your patient knows that you're not perfect. That's not the expectation. Just go in there and be real and try to connect with the person and do your best to be completely non-judgmental and treat the patient with unconditional positive regard.
yeah, and I think if you're being intentional about it and working on building your skills and leaning on mentors and faculty to help support and guide when you need to, and recognizing that we all have room for growth in this area, certainly myself included, then that's how you will grow and continue to be better and do a better job for your patients. So,
Well, you have been so generous with your time. Thank you so much for coming on the podcast. And
thanks for having me. So good.
Thanks for listening to this episode of Psychiatry Boot Camp. Please leave a rating and review. If you have questions or feedback for me, you can email me at psychiatrybootcamppodcast@gmail.com. The opinions shared in this podcast do not reflect the opinion of any institution, including host or guest employers or podcast partners. This podcast is not intended to be used as medical advice or in any legal proceedings whatsoever, including to establish a standard of care. This podcast is intended only as a supplement to a complete accredited psychiatry residency and is grossly inadequate to rely on for medical decision-making. It is intended to entertain and inform. You should always rely on your own clinical judgment when making medical decisions and contact your physician for medical advice.